Hi, I'm Pat Anderson, editor of MIMS Learning, and I wanted to tell you a little bit about the MIMS Learning subscription. This annual subscription gives you full access to exclusive subscriber content, ranging from clinical reviews to extended learning and recordings of our webinars. So come and check it out. If you take out a subscription, you'll find that it gives you stimulating learning, keeps you up to date on all the hot topics, and helps you with your appraisal process. So have a look today at the MIMS Learning subscription. You'll find it'll really add value to your learning.
Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Dawn Liz Powell, medical editor at MIMS Learning. Today I am delighted to welcome Bev Bostock to the podcast. Bev is an advanced nurse practitioner in long-term conditions. Not only is she the president-elect of the Primary Care Cardiovascular Society, but she is also a committee member of the Primary Care Respiratory Society and the asthma lead for the Association of Respiratory Nurses. Today, she will be talking to me about the management of chronic respiratory conditions. Welcome to the podcast, Bev.
Thank you very much for inviting me.
Okay, so when we say chronic respiratory conditions, I'm assuming we're talking about COPD and asthma, but what other chronic respiratory conditions might be seen in primary care?
Everything, quite honestly, because everybody that has a long-term condition that's affecting their respiratory system will at some point be under the care of the primary care team, whether it's a GP nurse, a clinical pharmacist. We all have a role to play. So yes, asthma and COPD, probably the bread and butter of what we do, but we'll also be seeing people with bronchiectasis, with pleural disease, with lung cancers, with a whole range of different conditions that need support from primary care. They'll probably only see their secondary care teams, if indeed they're under secondary care at all, maybe once or twice a year. So primary care has a huge role to play in the ongoing management of respiratory conditions.
Okay, well, should we start with asthma? Now, my colleague Sangeeta Krishnan spoke to Dr. Cara Bosley earlier this year about the management of asthma in children. So let's focus on asthma in adults. Asthma can develop in later life, can't it?
This is different, isn't it? There's a whole range of possibilities here, because you've got the individual who's actually been diagnosed with asthma in childhood, who still has it as an adult. So that is their ongoing condition. And of course, the management of asthma that started in childhood but persists into adulthood will be different from what it was when they were a child, but it's a continuum of the same condition. And then you have late onset asthma. If you're thinking about phenotypes, you've got a different phenotype there potentially. And it's really about what's driving that diagnosis. There might be issues such as a smoking history. There might be issues such as obesity that play a part. When you look at the underlying drivers, there might be less of the eosinophilic drivers that you see in a lot of childhood asthma. And that means that sometimes we have to manage it in a different way. So I think that the underlying concept of how we manage asthma is the same throughout childhood and into adulthood, in that it is an inflammatory condition that's managed with anti-inflammatory medication, which is primarily our inhaled corticosteroids. But in late onset asthma, what you often see there is a better response to the long-acting bronchodilators, and sometimes two long-acting bronchodilators, as well as the inhaled corticosteroid. So it's really important when we make a diagnosis to actually look at all the clues that lead us into deciding the best way to manage that individual.
So you're talking about lifestyle factors there, and I think you mentioned obesity. Obviously, obesity has not been out of the news in recent months. And I think there's been a lot of data flying about showing out the GLP-1 medications can have benefits with asthma. But is that related to the fact that if the person loses weight, then that asthma becomes easier to manage?
It's interesting. I think we're at very early stages of understanding what their role is. We know the GLP-1s have an anti-inflammatory effect, so obviously that could be potentially quite useful in asthma, but it depends whether the anti-inflammatory effect is one that works for the type of inflammation that we see in asthma. It will be a really interesting situation to monitor, and let's see when we get more evidence around that. But certainly we know that obesity can have a big impact on asthma stability, on the risk of exacerbations, on the likelihood of good control. When we think about the current position with the management of obesity, it's all about BMI of 40 plus and 4 comorbidities. And we haven't actually included asthma as a comorbidity within the 4 that are recommended. And I think that that's something that perhaps needs a rethink, because what I find is that when people change lifestyles and when they start to feel better, so that might be through quitting smoking or by losing weight, they actually engage with the more standard lifestyle changes such as dietary interventions and taking more physical exercise. It's much easier to exercise if you're actually feeling better, if your asthma's better controlled, if your joints aren't hurting. So that's probably a very interesting conversation for the future. The other thing that I would say about adult onset asthma, so asthma, maybe asthma that was present in childhood, then resolved and then recurred in adulthood. The one thing that we need to be very, very mindful of is the possibility of occupational asthma, because that is often how occupational asthma will present. So you see somebody who has had asthma as a child, they've had no problems at all, and then they've gone into a workplace where there are triggers for asthma. And of course, in that situation, if you do decide that it's occupational asthma, if you remove somebody from that environment, you can see the asthma completely resolve. It's an important diagnosis not to miss. So that's what I mean about it. It's so interesting because there's so many elements that we need to factor in here.
Just to go back and clarify something, when you mention the 4 comorbidities, I think the first stage of the rollout is going to those considered to be the highest need, and asthma currently isn't one of the 4 comorbidities that would make someone eligible for tirzepatide.
Yeah, indeed. That's the current situation. And, I think that the position that NICE has stated is that we know there are lots of other people who will benefit from these treatments in the future, but we have to start somewhere. So I completely understand why we've had to limit access at this stage of the game, but it feels like this could be an investment for the future. We'll see how it continues to roll out.
Okay, now going back to asthma, you made a reference to the fact that certain occupations can cause a recurrence of asthma in adults who had asthma as a child. Is this something young people with asthma need to be aware of, that certain occupations might be bad for their asthma?
Absolutely. I think that's something that we should be talking to people about, and we should be asking people about occupation. When we do annual reviews, and certainly if somebody does have an exacerbation or a recurrence of asthma that we thought was actually dormant, we really need to focus in on occupation history. So making people aware of occupations that might increase risk, but also making them aware of the fact that if their symptoms have recurred or indeed have got worse, could there be an occupational element there? I think we're not so good sometimes at thinking outside the box in terms of what might have triggered an exacerbation. And we know that very much these days, compared to perhaps how it was when I was leaving school and going into work, I left school, I went into nursing, and I've remained in nursing ever since. And that I don't think is so much of a thing these days. So even if we've got a previous history of somebody's occupation, we may not realise that they've moved on, or they're doing something different, or indeed they've taken up a hobby that might, increase the risk of them being exposed to some sort of noxious fumes. So yeah, all of that needs to be factored in.
So you're talking about occupations there, and you're talking about hobbies. Can you just clarify what occupations they might be and what hobbies might be that could trigger off an asthma exacerbation?
Yeah, so if somebody's maybe doing a lot of woodwork, either as a job or as a hobby, or they've got a big joy in making little models that use glues and stuff like that. There are all sorts of things that can trigger people off. Jobs, we often say about things like welding, things like hairdressing, anything really where there are things flying around in the air. Nail technicians, lots of nail technicians sort of buffing off all sorts of stuff that's flying around in the air that could lead to all sorts of problems in the future as well as in the present. So I think, baking, there are so many. I remember a patient that I saw once who actually worked in an office job, and it was clear that her symptoms were a lot worse when she was at work compared to when she was away from work. And we couldn't work out why that was when she was just sitting in an office. And I went through everything that I thought might have triggered her symptoms. And it turned out that she did work in an office, but it was the office of a factory that sold grass seed. And so there was loads and loads of grass seed in the depot outside of her office. And that's what was actually triggering her symptoms. So sometimes you have to be a bit of a detective to find out what's going on. And of course, there are people with asthma who can work in those occupations and don't have the symptoms. So it's very much an individualised approach, which we should be taking with everything, quite honestly.
I'm not going to discuss the direct management of asthma too much, as we have covered that in depth on our module on the asthma guidance that came out last year. But just as an overview, what is your impression of the guidance and what do you think of them?
Absolutely superb. I think they are really excellent. I mean, we were bringing up the rear. We're not particularly good in the UK. We're right at the top of the league for poor outcomes with asthma. And I suspect that that's about to change because we've finally taken on the approach that has been taken on in other countries with those guidelines that came out in November 2024. So I'm very excited about them. And I think that clinicians should be very excited about them and should be very, very confident about implementing them, whether we're talking air or MART. This is absolutely how we combine the art and the science of asthma management. And I think they've done a superb job. I was delighted with them.
So just for clarity, air is as needed, isn't it?
Yeah.
As needed dual therapy. And MART is maintenance and as needed therapy. And with both sort of regimens, it's one inhaler. So you've got, not one inhaler, but it's dual therapy with both regimens.
Absolutely. And it is one inhaler. So it's one technique. It's one to have with them. If they're taking it twice a day plus extras as needed, it's the same one. If they're taking it as and when they need it, it's one inhaler. It's such a simplified approach. It does make our life so much easier.
Just points out as well, which is, I'm sure people will know this, but there are different regimens based on age. So I think the MART and the air apply from those who are 12 and older.
Yeah.
There are different therapies for younger children.
Yeah.
Right, so moving now on to COPD. So COPD is very closely linked to smoking. But what other risk factors are there? I mean, I think obesity, again, is a risk factor for COPD.
Absolutely. I mean, the GOLD guidelines, the international guidelines, have come up with lots of subcategories of COPD. And so they've called them COPD, and then they've put a little letter at the end of it to say what they think that COPD is linked to. So COPD-C, as you say, is cigarette smoking, but actually includes cannabis and vaping, which is interesting because I think a lot of people see vaping as a way of not getting COPD potentially. They've got COPD-P, which is linked to pollution. I won't go through all of them, but they've got ones that are linked to abnormal lung development, often associated with premature delivery, low birth weights. They've got those that are associated with infection, those that have got a genetic predisposition, so that would be our alpha-1 antitrypsin deficiency. And we've also got COPD-A, which has been renamed so many times now. It used to be known as asthma COPD overlap syndrome, then it became asthma COPD overlap, and now they're recommending that we call it COPD-A, which is where you've got COPD with a history of asthma behind it.
Okay, so you're mentioning the GOLD guidelines there, and I think just to clarify, GPs and other primary care prescribers, they would use NICE as a guideline for what to prescribe, but I think with COPD, it's more that you would actually look at GOLD rather than NICE.
Unfortunately, NICE doesn't update its guidance on a regular basis. And when we get recommendations from organisations such as Gold, they are updated every year. So they do take into account developments that have happened. They potentially don't dig down into the evidence as hard as perhaps NICE does. But I think, it's really useful to have guidance that actually reflects, up-to-date thinking and specialist opinion on the topics. So I think when it comes to prescribing, actually both have good, solid recommendations. And sometimes it's a case of thinking, okay, what works best for this individual patient? Again, we come back to that personalised care.
And talking about new developments, the lung cancer screening programme is relatively new, and that's focused on people who are high risk for lung cancer, which will include people with a history of smoking. I mean, do you think this programme will also pick up people with COPD? And if that is the case, do you think this is to be welcomed?
It already is. Both of the respiratory organisations that I work with and the Primary Care Cardiovascular Society is getting quite a lot of traffic from people saying that individuals have had their scan done and they've been shown to have emphysema, they're asymptomatic, they're not aware of having any breathing problems. They've also potentially been diagnosed with coronary artery calcification, which would indicate underlying cardiovascular disease. So I think probably the powers that be are significantly underestimated these incidental findings that came up. And we're working at the moment, there is guidance that has come out about how to deal with incidental findings. There are some real differences of opinions out there as to what we should be doing. So if you find emphysema on somebody who claims to be asymptomatic, what are you going to do? Because there are some real leaders in COPD thinking who say they have COPD, they need treatment, and the earlier we start treatment, the less of a problem this is going to be in the future. And then we have others saying, let's get real. If an individual has no symptoms, are they necessarily going to be taking inhalers potentially every day that aren't going to make them necessarily feel any better, but again, could potentially protect them? I suppose in some ways it's like if you find somebody with evidence of coronary artery calcification and you recommend a statin, they don't have any symptoms from their coronary artery calcification, but we're still going to ask them to take a statin for the rest of their lives. So it's opened a whole plethora of questions and concerns and debates around what we do. But generally speaking, I would say, if we think about the 10-year plan, it's about prevention rather than cure. And although in both of those scenarios we haven't prevented because there is evidence of the disease there already on the scan, we can prevent that from getting worse. We can prevent the acute presentations of those conditions in the future with appropriate discussion with patients about how they want to play it.
But there is actually like a kind of a huge overlap between COPD and coronary artery disease, isn't there? I'm going to presume this because of shared risk factors.
Partly that. So yes, absolutely there are shared risk factors, but there's also shared pathophysiology as well. So things like inflammation, again, things like endothelial dysfunction. These are seen in people with both of the conditions. So there seems to be that shared pathophysiology. Certainly, if people are smoking, if they're overweight, if they don't exercise because they're breathless, then that COPD is likely to be comorbid with cardiovascular disease. But also we know that COPD is a condition where there's a real risk of exacerbations. And with every exacerbation, there is a significantly increased risk of somebody having a cardiovascular event. So we tended in the past to think COPD exacerbations were linked to future COPD exacerbations, which is absolutely true. So the focus then was on what can we do to reduce that future exacerbation risk, and it was all about using appropriate therapy, maybe considering the place for inhaled corticosteroids and triple therapy in those individuals to reduce risk, as well as pulmonary rehab, smoking cessation, all of the things that we know can improve outcomes. But actually, we're now saying that, we ought to be looking at these individuals, their blood pressure, their lipid profile. And, I always say that if you've got a patient with COPD who's not on a statin, you really need to ask yourself why, because it's pretty much a no-brainer. They're going to be high risk for a future cardiovascular event.
What do you mean by triple therapy? I think that's an ICS, it's an inhaled corticosteroid, a LABA, and what was the other one?
LAMA, yeah. So you've got your 2 bronchodilators in there, plus your inhaled corticosteroid, and you're giving them every opportunity to reduce exacerbation risk with those therapies, and also you'll optimize symptom control as well. So it's a bit of a win-win for everyone.
In terms of, say, a person does have confirmed cardiovascular disease and COPD, so how does the COPD affect the management of the cardiovascular disease and vice versa?
Well, the main thing I would say is prevention of exacerbations from the perspective that I've already put out there, that it is linked to an increased risk of a cardiovascular event. But also, we need to think about these individuals more holistically. We need to think about the hypertension, we need to think about the lipid management, we need to recognise they're at higher risk of comorbidities such as heart failure. So sometimes it can be quite difficult to unravel a patient who presents with symptoms that sound very much like their COPD, but actually could be the first indication of angina or of heart failure. So there's a lot that we need to do, and I think what we really need to do is recognise all of the things that we can do to reduce the risk of somebody having a cardiovascular event by optimising their COPD management. That will then lead into a lower risk of them having exacerbations of their COPD and that cardiovascular event, and then going on to develop things like heart failure. So we need more multimorbid type clinics. We're very much talking these days in the arena of diabetes and cardiovascular disease. We're talking about cardiovascular, renal, metabolic clinics, and I think we could even throw in some liver there as well, because we see that metabolic liver disease is starting to become something of a priority for NHS England. With our patients with COPD, we really need to be thinking about cardiopulmonary risk and really taking that overall holistic approach to reducing risk for the future and optimising quality of life, which will come with it.
Okay, so we talked about COPD, we talked about asthma. I think earlier on you made a reference to bronchiectasis. Are you able to provide an overview of this?
So I think bronchiectasis is a condition where it can actually coexist with asthma and COPD. And again, that's why we have to be real detectives in the work that we do to think about if somebody's presenting with specific symptoms, are we looking at something that is different from their asthma or COPD, or actually does that patient not even have asthma or COPD? Is it bronchiectasis? Bronchiectasis is a condition where patients produce a lot of phlegm, and as I say, it can coexist with asthma and COPD. Of course, in COPD, phlegm production is very much part of the picture that COPD presents with, but bronchiectasis is often related to some damage that's been done to the lungs at some point, and it allows a lot of mucus to accumulate, and you'll find that patients often bring up a lot of sputum during the day. The only way that we can actually diagnose bronchiectasis is with a high resolution CT scan, so it's important to make sure that people get access to that, and then we have to think about how we manage it. And there are nice guidelines out there that help us to manage bronchiectasis, but it's very important to make sure that as much as possible the focus is on keeping those lungs clear of that sputum, because it is a real breeding ground for potential infections. So we want to get that phlegm out. We can do that with medication. We can do that with chest clearance devices and with chest clearance techniques. So we work closely with our physiotherapy colleagues on that. It's always basically to keep the chest clear, and that's important whether it's a standalone diagnosis or whether it's a comorbidity of asthma or COPD.
Okay, generally, how can living with a long-term respiratory condition affect a person's quality of life?
Well, it's interesting, isn't it? Because breathing is pretty essential for maintaining a good quality of life. And often when you ask people about what symptoms they fear for example, at end of life, it's being breathless. Being breathless sometimes impacts on people from a psychological point of view as much as from a physiological point of view. So I think that it's really important that we help people to understand why breathlessness happens, and to understand that usually it's not an indication that they shouldn't exercise or that they shouldn't try and lead a normal life. It's about managing that breathlessness. And we have lots of opportunities to improve with pharmacological interventions and with things like cognitive behavioural therapy that have been shown to be very, very effective in managing that. With things like asthma, I would say, when we think about some of our high-level sports people who manage to do that high-level sport with asthma, it's important for people to recognise that they should be able to do whatever they want to do with asthma. We should be able to reverse this condition. That's one of the features of asthma, is it's reversible with the right management. So it's important that people have access to that right management. And with COPD, I think it's very important that we deal with the symptoms that stop people from being able to engage in the social activities that they want to do, staying at work, all of those sorts of things. And we have lots of potential to do that. So I think we just need to be aware as clinicians of all the opportunities that are available to us, whether it's pulmonary rehab, whether it's inhalers, whether it's other oral medications, and really support people to expect more. I think we should expect more as clinicians, and we should encourage patients to expect more. So let's make sure that yes, there are challenges, but actually the challenges usually come with some really good and fairly simple answers. So let's just do it.
Finally, what are your take-home messages about long-term respiratory conditions?
Yeah, I would say my take-home message is to be aware of the evidence, to implement the evidence, but always be aware of the individual that you're working with, because we're experts in our clinical areas. They're experts in them. If it was a one-size-fits-all approach, life would be very much more straightforward, but it isn't, and that is what makes life very much more interesting. So always personalised care, working with the individual, but giving them our best to make sure they have an opportunity to live a full and long life. That would be my take home.
Thank you so much for speaking to me today, and thank you to our listeners for joining us. Don't forget that you can claim CPD credits for listening to these podcasts, and there are plenty more on the MIMS Learning website. I've been Dawn Liz Powell, speaking to Bev Bostock, and this episode was produced by Jude Owen. Look out for our next episode, where the MIMS Learning editorial team will bring more highlights from the comprehensive CPD modules we have on our website.